So here are some specifics when we're talking about vaccine sites, breaking them down by age. So newborn, that's considered the first month of life essentially. The vastus lateralis is which is the site you're going to be using for IM injections. When we get to the infant stage, this is anywhere up to from 1 month up to 12 months of age. We're still using the vastus lateralis. And for a toddler, they recommend, and this is 1 to 2 years of age, the vastus lateralis. Alternate sites deltoid if it's large enough. Having said that, I've also had doctors instruct me to go ahead and use the gluteus maximus, so we're doing it through the glute in newborns. So that can be an option as well, but these are your most primary ones. You can usually think up to about 2 years of age, you can do those shots in the leg. That's actually a benefit for you as far as MAs go. Of course, the newborns, they're very easy to deal with. The 1 to 12 month old are usually pretty easy to deal with. They're going to get fussy, but they're still small enough that, between the parent and the MA, you can stabilize that leg pretty easily and get those immunizations done. Then we get in the 1 to 2 year range, things get a little bit more challenging. So sometimes we have to pick an alternate route there. So I have had parents and doctors alike have me do glute injections on toddlers as opposed to trying to do it in the leg, especially if the deltoid muscle was underdeveloped, or I shouldn't say underdeveloped, but not yet adequate to receive that type of injection. We get into the children years, 3 to 18 years of age. This is going to be the deltoid now. So after 3, you can start thinking about that. For the younger ones, vastus lateralis is an alternative. Glute may be an alternative if the situation presents. These are the more problematic years, especially getting up to that last round of childhood immunizations around the 2nd and 3rd grade. Also going into 5th and 6th grade, they require boosters of Tdap and so on and so forth. Here's where, the craft of giving injections is going to meet the art of giving injections. And that's how to reason with someone who really, really, really does not want to do this. And you'll develop those skills with time. In this class, we're focusing primarily on how to give the injections. Once we get to adults, 19 years and older, it's pretty much the deltoid. Vastus lateralis, of course, is always an option. And once again, glute, depending on the medication and the patient. We like to think after we get past 18 years of age that giving these injections might get easier. That's not necessarily true. I've had full-blown adults that have had panic attacks and adverse reactions. And as MAs, we just do our best to convince them that they're safe. We're going to get this done. As some of you may have experienced when we did the self-administered sub-Q injections, it's a bit nerve-wracking at first, and then once it's complete, usually the reaction is, oh, that wasn't so bad. And I've had this many, many times with children and many, many times with adults, where there'll be a lot of anxiety, sometimes some combative behavior. You administer the injection, and then the reaction is like, oh, whatever. And generally speaking, if there's a lot of nervousness and maybe a little bit of drama, it almost always resolves immediately after the injection is done. As soon as they know that they don't have to be afraid of it anymore, they resolve very quickly. So please be patient with your patients. It's not always easy, especially on a busy day, and sometimes you might have to take a few more minutes. But you'll do a much better job at convincing that the patient and the parents of the patient, in the case of a child, that you really are calm, kind, and considerate by taking a little bit of extra time. So always consider that. Never try to rush someone through a vaccine or an injection, and never try to force that on them. If they ultimately say no, the patient has the right to refuse it, and we have to respect that right. So if you get a refusal from a patient or from the parent of a patient, report it to your supervisor or your doctor, whoever gave you the order for the injection, and they will advise you from that point forward. All right. Deltoid. There it is. That's pretty much the way we look at it. Do pay attention to this anatomy. If you don't know what the acromion process is, it's that shoulder bone you feel right at the top. If you go all the way out to the end of your arm and palpate it, you'll find the acromion right there. That's a very important landmark for us. And if you look all the way far right on this drawing, it shows you sort of the triangle within which you will do a deltoid injection. So this is very specific information about intramuscular injections. Look it over and be familiar with it. You may be tested on it. I'm willing to bet once you get in practice, this will probably simplify a little bit. They're very specific with the weights and the sizes here. And once again, you may be tested on this material, so know these ranges. But to be honest with you, In practice, it's usually the 1-inch needle that we use, despite these recommendations here. I would say for in that last category, for a female over 200 and a male over 260, that 1.5-inch needle is probably appropriate. I've used it a few times in a deltoid, but I've also found 1-inch to be pretty effective in those cases. Reason being is that if there's a heavy layer of subcu tissue, usually you can push down into it with the syringe. It'll just naturally go there, and you'll still get inside that muscle. So these are really good recommendations. I wouldn't say that you should live or die by them, but you certainly should know them and be aware of them. And in the general sense, they're pretty accurate. So some of the guidelines. You want to administer in the central and the thickest portion of the muscle. You want to have the patient in a sitting position. You want to have the arm and shoulder fully exposed. The arm should be the arm getting the injection, by the way, and that arm should be loose and hanging at the side with a relaxed muscle. There's going to be enough tension already, especially if there's any anxiety about this. The tighter those muscles are, the more painful the injection is going to be for the patient. And we'll cover this next part in class, but you're going to locate the acromion process and the axillary line, and between those two lines will be your target area. And you're going to administer approximately 2 to 3 finger widths below the acromion process. That is a very reliable guide on almost every patient. I've rarely, if ever, have seen an exception to that. We'll cover all that in class. Of course, the other guidelines, things we want to think about, and that was addressed in the graph a few slides back. Needle length, we want to make sure we come in at 90 degrees in a quick darting motion. So it doesn't mean hard, it just means kind of a quick insertion. When we depress the plunger, we want to do it slowly and steadily. So if you do it too fast, you'll separate the muscle fibers and cause pain. If you go too slow, it's going to cause pain. There's a spot right in the middle. It's kind of a sweet spot. If you can find where that is, you'll notice that most people will say, wow, I didn't even feel that. And by the way, that's going to be about 50 to 60% of the people you give injections to. They're going to be not nervous. They're going to be cool with it. You give them a shot, they'll say, no big deal. Engaging in conversation, by the way, is a good way to distract a patient. I've many times when I've had conversations with patients, I've given them the injection while we're talking, and then I walk around and drop the syringe in the sharps container, and they'll say something like, oh, we're already done? So you can distract, and it works really well. Anyway, you want to go slow and steadily so you don't create too much pain. You want to use a non-dominant arm when possible. So you'll always ask a patient, are you right or left-handed? They may say, I only want it in the left or only in the right. Please oblige the request. If they don't want it in either arm, you have to start exploring other sites. That could happen, but it's not a strong likelihood. And maximum volume of about 1 mil for a deltoid. And that's going to cover most of the IMs injections that we do as far as volume goes. Now we're talking about the vastus lateralis. So this is that anterolateral muscle that we have on the thigh. You see it here depicted on a small infant, and this is the age range that you're going to be doing this. Technique here, if you can, if the child can be fed, either bottle fed or breastfed while you're doing the procedure, it's helpful. Sometimes you need an extra parent, one just to hold the leg stable while you kind of work on the patient. Some situations you'll have to do it alone. And I've had many experiences where mom has breastfed the child and held the leg for me and stabilized it so I could deliver the injection. So that's the location of it. Once again, it's the anterolateral aspect of the thigh, and that's not fig, it's thigh. So we have a word misspelled here. It may be corrected by the time you hear this, but do know that right now it's the anterolateral aspect of the thigh, not the fig. It's generally thick and well developed in patients of all ages. It's not located next to any major blood vessels or nerves, and it's easily accessible to do IMs. So that's one of the reasons we use it on that age group. Some of our guidelines and considerations. So patient, it generally is going to be supine, possibly sitting if they're a little bit older, but generally supine. What you're going to do is locate the greater trochanter and the lateral femoral condyle. I will teach you how to do that. These are landmarks we use in radiology all the time. They're not that difficult to find. Some of you may already know how to find them. These are very effective landmarks, and they're very consistent, just like the acromion process is. So I will use my knowledge as an RT to help you locate those two landmarks. We didn't mention this. This wasn't mentioned before. But you're going to measure with the hands, a width above the knee, and a hand's width below the greater trochanter, and that's going to be your location site. Now, the thing about that hands width measurement they're talking about here, that's going to be relative to the size of your hands and relative to the size of the patient. So that's going to be a differential a little bit. Of course, once again, we want to pick a long enough needle, insert it 90 degrees, administer slowly, and in this muscle, we can go up to a volume of 2 mil. And for some childhood immunizations, especially combo immunizations, you may be doing 2 mil in one injection. The good news with that is you might be, or if you're using that level with vaccines, you're probably administering 2 or 3 vaccines that are mixed together, which means instead of 2 or 3 shots, you're doing it all at once. So that's going to be very helpful. So measuring with the hands, let's get back to that a little bit. When it comes to vastus lateralis, you can use this technique for hand measurement. We'll show it to you here. So we have a hand width on the far left. That's right at the greater trochanter. You see the left hand is placed there. So going a hand width down from there in the middle picture, and then another hand width up from the knee, as you see in the middle picture. And right in that area is where you're going to do the injection. Honestly speaking, and this is a great technique, and you certainly should use it in practice, and so you get used to seeing that site. Once you've done this a few times, you'll be able to see that site right away, and you'll understand where the muscle is. And there are other ways of finding it. We'll cover some of those in class. This is one method that can be used. But once again, if you have a very short patient, someone with a short leg, if you're doing this on an infant, or if you have very long or short hands, this is going to be a relative measurement. So you can use this as a guide. It's also best to know exactly where the vastus lateralis is located, so that, located anatomically, I should say, so that you can sort of look at the leg and assess where it's going to be right away. And on that note, also when it comes to finding the deltoid muscle in the appropriate spot, 2 inches or 2 or 3 finger widths down from the acromion process, after you do enough of these, you'll be able to look at the patient and see exactly where the injection site is without measurement. But in your first several, I highly recommend that you use these landmarks to locate the appropriate injection site, so that you make sure you get it in the correct muscle. All right, we're going to end this section here. I'll be back in a moment, and we're going to have another site for you, and we're going to discuss that in just one moment.